everyone, it's Lorie Brown with our special series, COVID-19 Survival Guide for Nurses and Healthcare Professionals. And today our special guest is Paula Scimeca. And Paula is very interesting. She's one of the leading experts on addictions. And she also learned how to make mohair teddy bears to help relieve some of the stress after she became the leading expert in addictions. Interesting, huh? So welcome, Paula.
Thank you for having me.
I'm so glad you're here. And you're probably wondering, our listeners are probably wondering, why do we have an addictions expert on this program? And that is because now, more than any time, nurses are so prone to seek those comfort things. And it's so easy to get addicted. So Paula, let's first learn about you, and then we'll talk about how nurses can protect themselves. So tell me about yourself. How did you get interested in this?
Well, I became a nurse I graduated from Adelphi University with a bachelor's in nursing in 1975. One of the first places I had to float, I was working on a med-surg unit for the first 2 years in New York City, a New York City hospital. And one of the first places I floated was a detox unit. And I was so uncomfortable. It wasn't until after I had done a stint of maybe eight years after that in intensive care predominantly, that one of my friends who was a nurse kept lobbying for me to go to the psych and the detox units. And she said, "You'd be great." I said, "No, not interested, not interested." But it came a point where those were the two areas that offered a per diem shift that was 7P to 11P, which was extremely excellent when you have toddlers at home. So I jumped that was a big divide. I had become, quite interested in addiction before that, simply because we had a lot of critical patients that were in ICU strictly because of their addiction. I'll never forget having a woman come over from the OR in a coma in her early 60s who during the surgery, she convulsed because she was in DTs. She was NPO after midnight. She seized and she never came out of it. She died. So, there certainly is a need, and no one escapes, I don't think, in today's day and age without knowing a lot of people, nurses included, who have a problem with alcohol and another drug.
Yeah. And so it's interesting because just like a virus does not discriminate between age, sex, race, religion, neither does addiction or socioeconomic status. It could happen to anybody.
It does. It does. It happens across the map. Rich, poor, young, old, educated, uneducated. One of the interesting things that I find, Lorie, is that a lot of people who are educated tend to think that because of their education, they are imbued with some type of resistance or invulnerability to it. And that's where we come in, especially with nurses, that pharmaceutical invincibility. Because I know how to safely and effectively medicate patients, I therefore can take that big leap and self-medicate. And that is absolutely untrue, simply because as nurses, we can safely and effectively medicate patients because we are the witness to all those observations we make. How is the nurse how is the patient tolerating the medication? Is it working? How frequently is the dose? And nurses get into trouble quite frequently. We're used to medications and we know that a lot of them are safe, but it doesn't mean that we don't become, problematic users.
Yeah, so interesting because I get a lot of nurses before the board that are like, "Oh, I had some back pain and I borrowed like an oxycodone from somebody," and they don't realize that the boards consider this practicing medicine without a license. And it's also diversion because you're taking a medication from somebody else for your own personal use.
Yes, and how frequently have nurses who have had to split a pill go into the patient's room, they split the pill, they put in their pocket, intending to make it, and waste is such a horrible phrase that we use, wasting medication, because it makes nurses believe that this was just something that was going in the garbage and it isn't owned by somebody. You know, Medicare, Medicaid, all of those insurance companies, they own that half a pill. So that is theft and it is fraud. You know, it's Medicaid fraud, and a lot of nurses don't consider that. They think, but no harm, no foul. That was going in the garbage or down the drain. So it is extremely, you know. But that phrase, wasting medication, you know, we should be saying what it really is. You know, medication that was not utilized and is going to be destroyed, or something like that.
Yeah. And so why is now like a time where it's so important for nurses to take care of themselves and not seek comfort with alcohol or drugs?
It's interesting that you asked that question, because after 9/11, one of the things that I was asked to do was go on a public radio program about stress and how to manage stress after 9/11, having been in the New York area, you know, during 9/11. And, you know, all of the panelists spoke about stress, and the brain understands that, you know, alcohol and other drugs work. You know, they do take away emotional pain as well as physical pain. However, there's a back end to that when the individual becomes habituated to using and not using other coping mechanisms. And it's one of the reasons why oftentimes nurses or other individuals in recovery fare much better in a crisis situation if they've been in a solid, uninterrupted recovery. Because in order to get into that recovery, Lorie, they have had to develop coping skills and develop them to a very, very enhanced degree that a lot of people in the public don't have to. You know, so by and large, yes, a stressful time, and yes, people in recovery need to be concerned that they are keeping pace with what they need to do in self-care. You know, even those that aren't in recovery, self-care is paramount. However, you know, nurses in recovery do quite well. You know, they do as well, and oftentimes better than other individuals who have not really had to go through the devastation of having a substance use disorder. And just a word about state monitoring programs, Lorie. You know, the one thing that I am very concerned about during this crisis, I'm very, very glad that some of the states, I'm in an area that is the hotspot, New Jersey and New York, are the hotspots, looking for health professionals to come into the state to help with the surge of COVID-19 patients. I'm very, very glad to hear at least one of the individuals that was talking about the state of New Jersey, how they're being very, very careful in vetting any professionals that are coming from out of state, and making sure that there are no disciplinary issues. You know, the one thing that I do have a great concern about is nurses who have been identified in the workplace, and the workplace, instead of reporting them, has said, we'll help you through this. You know, because I know the goal of the hospital is there to take care of patients. Their primary objective is not making sure that the nurse is safe and that the public is safe. They are taking care of patients. And when push comes to shove, those nurses are going to be pressed hard in this surge. You know, the great thing about the monitoring programs is they are third parties who are making sure that the nurse is monitored in a manner where they're safe to go back to practice, and they continue to monitor them. So those nurses, there is an objective bystander who's making sure that that nurse is safe to practice. Mm-hmm. You know, when there isn't, you know, those are the individuals that I feel that are really the sticky widget. You know, they could become, you know, an issue. You know, because there still are, you know, entities that think, oh, we're just going to handle this, and they never report. They'll identify a problem in the workplace, and we're going to handle it, and they handle it poorly,
Yeah.
in my humble opinion and in my professional experience.
So I want to ask you about three categories. One
Sure.
is the nurse with substance abuse. The second, the nurse who thinks she might have a substance abuse problem, and the third is how to prevent a substance abuse problem. So during this difficult time, do you have tips and strategies for all three categories? So
Well, let me start with the person who doesn't have an issue.
Okay.
You know, in radiology, there is a term, ALARA, ALARA, as low as reasonably achievable. You know, a lot of people will drink alcohol, and the majority have no problem, okay? But in drinking alcohol, we should be treating it like with that principle of ALARA. If you're on pain medication that you've been ordered for a legitimate pain syndrome, as low as reasonably achievable. You know, don't be taking extra, because with each exposure, you're upping the chance that you are going to get into a risky area. You know, substance use disorders are a continuum. You know, in utero, most of us have not been exposed to habit-forming substances like opioids, okay? So most of us are born as non-users. And then as we progress on our, you know, chronology, we start using alcohol, may start using other habit-forming medications or drugs, licit or illicit, legal or illegal. And we can, if we're using, we go from non-user to user. You might have problematic use, misuse, you know, using in a way that was never intended, like Nurse Jackie is crushing the pill and snorting it. So that's how you progress. It's a progressive, but nurses being nurses and having the access we have to the gamut of pharmaceuticals, generally speaking, a lot of times nurses will progress in that continuum very quickly. You know, I had a nurse who, you know, when I was working with, you know, over 500 nurses in New York years ago, who were in the monitoring program, progressed very, very, very rapidly from a non-user to 80 Vicodins a day.
Wow.
Not 80 milligrams, 80 pills. And in fact, when the law enforcement got to her, they were going to prosecute her for distribution, because they thought it's impossible that she's using that much, but she was. So, you know, the advice to everybody is as low as reasonably achievable. And if you don't use, don't start. For the nurse that thinks they have a problem, get help. You know, check online. We have a lot of information that we can get on the internet. Not all of it is, you know, is real and valid, but if you're going to your state regulatory program, they can certainly point you in some directions. A lot of states now have peer assistance programs. If you're a nurse anesthetist, the American Association of Nurse Anesthetists has a peer assistance program, you know, that you can access. A lot of nurses can also access some of these, you know, available resources. And if you know you have a problem, well, I can divide you into two categories. I can divide you into the person that's in recovery now, you know, and you need to do due diligence and double due diligence in the stressful time, as far as going to 12-step meetings, you know, if you're in therapy, calling your therapist, calling a sponsor. You know, you have a support system. If you're in recovery, use it to the nth degree possible. And if you know you have a problem and you're not in recovery, there's no better time than now to get into recovery. There are so many comorbidities that go along with substance use disorders. You know, whether it's a kidney problem, a liver problem, which none of that bodes well for any acute condition, including COVID-19.
And I believe you told me when we talked previously, the best way to avoid having a substance abuse problem is to never start. So if you don't take any controlled substances or drink alcohol and even marijuana, don't start. It's not worth it.
And especially if you have a family history, genetic loading, that family history. I knew long ago my genetic loading was such that I would have had a problem with alcohol. So I stopped drinking back in 1982. It wasn't that I had a problem drinking and driving, a problem with the law, a problem falling down, it wasn't a problem. Interestingly enough, after I had stopped drinking for 6 months, when stress came along, I wanted not a drink, I wanted a jug to numb the stress. But the important thing is I could see that and realize I wasn't on that other side where you cross that line from being a non-alcoholic into an alcoholic. So, very, very important for people to look at their individual situation. It really is very, very important, and be honest with yourself. And that's one of the things that a monitoring program or a 12-step program is very, very helpful with, because they'll call you on your stuff. If you're doing something that you shouldn't be doing, and I always said to the nurses that were in the statewide peer assistance for nurses program in New York, I always told them, I'm not here to advocate for your disease. I'm here to advocate for you as a nurse. I am not going to tell you anything that is not the absolute, and you might not like it, but I'm going to say it. I have to be honest and truthful with you. And nurses appreciated that when they were doing the right thing. They did not appreciate it when, I was saying, no, I don't think this nurse should be going back to work, or I don't think they should be able to work overtime or whatever. So,
what we're also seeing is, I think because of the opiate crisis, the boards are going a little bit overboard, in my experience.
In what way?
In terms of, like, if you are, well, one is the recovery program in the state where I'm licensed, Indiana, is an abstinence-based program.
Mm-hmm.
And so nurses who take maybe Adderall or something for chronic pain, they are not allowed to be in the program.
I have to say that New York is abstinence-based too. When I was with statewide peer assistance for nurses, and there was not one nurse with a chronic pain syndrome who was misusing, abusing their opioid, who did not tell me once they stopped using and they got through withdrawal, my pain is better managed with Tylenol or a non-steroidal anti-inflammatory. And the reason for that is because there is such a thing as opioid-induced hyperalgesia. There have been studies on it, that after even one dose of an opioid, the sensitivity, the sensation of pain can be increased rather than decreased. So that dovetails with not only the opioid that you develop tolerance and increase the dose due to tolerance, but you increase the dose also because of opioid-induced hyperalgesia. And that's a very, very important caveat that most people, including nurses, do not understand. But the nurses told me, hey, I'm better relieved now that I'm taking Tylenol. I'm not taking 80 Vicodin, but I'm in less pain. Go figure.
Yeah, I've heard that before, but I didn't know the science behind it with the opioid-induced hyperalgesia.
Yeah,
so that's so interesting.
Yeah.
And the other area that I'm seeing is that nurses who just forget to sign out meds or forget to have somebody to waste on just a couple of occasions, they go to monitoring and they're like, I have to go to these meetings and, I just don't feel like I belong. But from what I do hear from the people that do go to the meetings, there's so much personal growth that happens that they're such a different person as a result of it.
And interestingly enough, I have to say, it's usually, this is, substance use disorders in nurses is very interesting, Lorie, because by and large, a lot of the nurses that develop a problem on the job are the nurses. They are the go-to nurses, just like is portrayed with Nurse Jackie, but they also graduated at the top third of their class. They're movers and shakers. You know, in recovery, they're also movers and shakers, and they do quite well. You know, when I got those 29 stories of nurses, you know, their story of addiction and their story in long-term recovery, what was quite interesting that I've seen over the years is, I would say at least, at this count, at least 5 or 6 of them have doctoral degrees in nursing.
Wow.
You know, how many nurses, if you took any 30 nurses, and okay, how many of you have doctoral degrees? You're not going to find that 20% have them. So, you know, they are, you know, it's a very, very interesting cohort. It really is.
Yeah, it is. And yeah, I love seeing them on the other side. It is just, it's night and day.
Yes, and that's the nurse that I want taking care of me. Yeah. The nurse that's gone through monitoring is the nurse that I want taking care of myself and my family. Simply because they listen, they understand what it's like having been on the treatments, you know what it's like being the treater when you're a nurse. It's very, very difficult to understand the patient experience. But for nurses that are in monitoring, particularly those that have been in monitoring, they understand what it's like to be the identified patient. And that's awesome, because they listen to patients. They take things very, very seriously. You know, the nurses that don't, generally the nurses too that get into trouble with substance use disorders are the nurses that care the most. Yeah. They're not the nurses that go home and don't care about how they left the patient. It's the nurse that cares the most, because they have that stress that, you know, the nurse that doesn't care is not stressed about that. So, you know, those are the nurses too that are at risk.
Yeah. And I think that the nurses in recovery are even stronger because they want to protect their license. They have, you know, I think a lot of nurses, they take it for granted until something happens. And then once it does, it's like, oh, this is too important. And they're hyper aware and really want to do everything right.
Nurses, as nurses, even as, you know, licensed, you know, drivers on the road, we tend to take for granted that it's a privilege to be able to operate a motor vehicle. It's a privilege to be able to practice a profession. It's an extreme privilege, I think, to be able to practice nursing. But we tend to forget that. For the nurse that has had that license on the line and held in abeyance for them to get themselves in a solid recovery, they really, really appreciate what a nursing license means. They so appreciate it. Greater than the person that's never had it at risk. You know, just like if my health is at risk, you know, if I'm one of these COVID-19 patients, I'm going to appreciate my health, you know, today, more so than the person that's just, you know, feeling great and thinks that they're above it, you know. And that's the thing too. You know, the person that's most at risk for COVID-19 or the permanent condition of a substance use disorder is the person that thinks they can't get it.
Yeah, it's fairly scary. So I'm going to switch gears a little bit. Sure. Let's hear about these mohair teddy bears.
Oh my heavens. I can show you one I have sitting right here.
Oh, okay. Oh, wow. Wow. Yeah. And you made that?
I'm sorry?
You made that?
Yes. And he's fully jointed and yeah. He's
cool.
Actually, this is a girl. I forgot. This is Francis. I had to name them, you know, when I make them. Yeah. It was very interesting when I started making teddy bears because my daughter was going off to college, Lorie, and I made her one, brought it up to, you know, college so she could have it at college. And my husband at the time had said to me, you know, you really should ask your son if he wants one. And I said, I don't think, he says, just ask him if he wants one. Now, my son at the time was maybe, I don't know, 14 years old, which to me is not a time when a kid wants, a male a boy, a son wants a teddy bear. But as soon as I asked him, it was so funny, Lorie, because he says to me, he says, yes, and I want it to look like this teddy bear, and I want it to be this kind of fur, and I want it to have a Rangers jersey.
That's so funny. How did you get interested in making them?
I saw, I had gone and seen a teddy bear that I loved. The mohair teddy bears, the designer bears are like $300 each, and I was like, oh, I don't, there were some I liked, but I said, you know what, let me, I knew how to sew. So I took a class in Edison, New Jersey from one of the designers who I liked her bears. And then it was fun. It was fun. And there's a lot of different things to do, as far as, if you're going to fully joint it, you have to get good with a screwdriver and a socket wrench and things like that. So, which I kind of like doing things like that too. So.
That's great. That's good stress relief.
Yes.
So interesting. And now you're the author of 2 books, right?
Yes. I wrote the first book, Unbecoming a Nurse, which outlines the issue of substance use disorders in nurses, as well as it talks a little bit about monitoring programs, alternative to discipline programs, talks about the need for the nurse to take a step back from practice, oftentimes, very, very often, because they need to put their health first, their recovery first. I wrote that in response to when I was working in New York for statewide peer assistance for nurses in rapid succession after doing it for 5 years. And part of my role was to go out and do outreach at the nursing programs in the area. I had a catchment of 55,000 licensed RNs and LPNs. And part of my role was to go out to all the nursing schools and, give a lecture so that for me, I was giving a lecture so they would never need to have me sit with them before the board because they had an issue. And in rapid succession, in right about this time or, later, maybe May or June of 2008, I had 3 nurses in rapid succession who, when I met them for the interview, said, oh, I remember when you lectured at my school, and it was a kick in the gut to me because that wasn't why I lectured, so they had my contact information. I lectured so that they would never need me. And I said to my husband, I said, it's not enough to just do a lecture in nursing school for the students. It's just not enough to go around to the hospitals and talk about this issue. I need to write a book on it, and I will not mince words. I need to say what needs to be said, so I'll need to self-publish, and it's a conflict of interest with my job. Never thinking anything of it. And 3 days later, this was right before the economy tanked in 2008, my husband hands me a checkbook and says, here, go write your book. And I put in my resignation, and I wrote the book with every intention of getting back in the workforce immediately. I had a deadline. I was when I sent in my that I was leaving the job. My last day was August 7th or 8th of 2008, and I had in mind I was going to have the book out by January 1, and I did. I wrote like nothing, and I didn't want Amazon. I didn't want to line Amazon's pockets at the expense of nurses who were desperately in need of the book. So I decided to, get a website and sell it myself just for whatever it was. But before the ink was even dry on that first book, Lorie, I realized it's not enough to outline a problem, especially when there are so many, thousands and thousands of nurses in recovery, long-term recovery, permanent, uninterrupted recovery. So I realized I would need to also write a book of nurses telling their story of addiction as well as recovery. And I had 29 nurses from various states in the country. Actually, two of the 29, 2 of the stories were told by the husbands of nurses who had died of cancer unrelated to their addiction. One died 30 years in recovery, the other died 18 years in recovery. And to me, to understand that, and this really speaks to the the strength, the resilience of recovery. These nurses died in recovery, combating cancer. You know, it doesn't get better than that to really understand that recovery is something that it does not have to be. Relapse is not a requirement for recovery, and it's very, very important that people understand that, because the headline grabbers are, oh, this person had a horrific relapse, this person did this, the horrible things, rather than, this nurse, had 30 years in recovery, stayed in recovery, continued to help others while she was combating cancer, So there was a nurse who gave her story who found out when she was in treatment that she was HIV positive, found out right before she left treatment. She was in long-term treatment for over a year, found out before she left treatment that her youngest son was HIV positive. Mm-hmm. And she nursed him while he, for the next 3 years, she went back to work. But she nursed him, and he died at the age of 12, But she said, relapse is not an option. It would just make things worse and crazier. And she had her other son, her elder son, to be concerned about, as well as her own recovery. Recovery happens. Recovery happens. It's not a headline grabber, quite like relapse is. But people need to really, and that's why it's so important for nurses to be well-grounded in 12-step programs and peer support programs.
Yeah, definitely. Well, Paula, you've been so gracious to share your knowledge, and I know how passionate you were about writing that first book. You quit your job over it, and you just felt it was so important to get out into the world and how to help nurses. And Paula has been so kind to every one of you listeners out there. She is giving her Unbecoming a Nurse book for free, the ebook version, which will be with this video. So thank you, Paula.
That's actually the second book. The book with the stories is the second book, and that's the one that I was able to get an electronic version out to you this morning. So the other one I'm working on, and when I get it, I will certainly send that to you as well.
Oh, so you're going to give both books?
Yes, once I can get the electronic version for the first. Yeah, I figured, truthfully, in this time of stress, Lorie, I and I think a lot of people love hearing stories, true stories of people that have overcome almost impossible odds. Yes. And so that's why I wanted to get to you the second book, which was the book of stories. Which really talks about what nurses have gone through, and the stories by the husbands of the two nurses who died of cancer. I don't think there's anything more uplifting than really seeing that people do recover. Nurses do recover. They go back to work.
They actually do better than the general public because yes. They have their license on the line, is what I understand.
Yes.
So that is just so kind of you.
Yes, nurses, doctors, pilots do extremely well, but that's because the carrot dangled in front of them is the ability to do what they love, to practice their profession.
Yeah. Well, thank you. That is so kind. So you'll see the both books attached to this video, and again, I can't thank you enough. That is so kind. And in this time, of crisis for nurses, that's why I'm doing this video series. In closing, again, thank you so much for taking the time to speak with me today. And for our listeners, please, if you have a substance use disorder, get help. It's a medical problem. You didn't wake up one day and say, I'm going to do this. It's not your fault, but it is your fault if you don't get the help you need. And there are so many people relying on you, and we need you now. We need you healthy. We need you whole. We need you here to help during this crisis. And so, if you know anybody else who'd be interested in watching these videos as well, have them sign up at empowerednurses.org/COVID. And please share this with everybody. And let's get Paula's book into the hands of all nurses, because if we can stop nurses from having substance use disorders, even better. We'll be a much healthier society for it.
Amen to that.
Well, thank you. And
Thank you for having me.
so for now, bye everybody. Thanks for listening. We'll see you on the next video. Bye.